Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our Conversation with Experts series, we have one of the leading myeloma folks from the west of the United States, Dr. Jeffrey Matous, who is a clinical professor of medicine at University of Colorado and is running the Colorado Blood Cancer Institute myeloma effort with the Sarah Cannon Research Institute. He's been a lead accruer on a lot of trials, including the trial we're going to talk about. We're really fortunate to have him. So, Jeff, welcome.
Hey, Ravi, it's a real pleasure to be here and to be part of My Cancer Haven. Thank you for the invitation.
So, Jeff, to put it in perspective, what is extramedullary disease?
So, extramedullary disease is, I think, as you know, it's one of the major challenges that we as myeloma physicians have and encounter in our patients. And extramedullary disease, I think, needs to be contrasted to paramedullary disease. So, paramedullary disease is when myeloma tumors form off a bony substrate, if you will. And we see those often around the spine, for example, or rib lesions, that sort of thing. True extramedullary disease arises outside of, it is not contiguous to bone. So that can be in organs, such as we've seen in the liver, we've seen it in the lung, it can be in muscle, it can be in skin, in different places. And the problem with true extramedullary disease is that very often it's a late finding in our patients with myeloma. It's a sign of more aggressive and more evolved disease. And traditionally, very often, it's also been what we call hypo or oligosecretory, meaning that the cells are so screwed up, if you will, that they have forgotten how to make their myeloma protein marker. And so in the past, these patients have been excluded from clinical trials, which has made it all the more difficult for us. And we know also that patients with true EMD, Ravi, as you know, they just do poorly relative to other patients with respect to our treatments.
So, in terms of the advances in myeloma, we've seen tremendous advances. We're going to talk about this redirect study, but how have these new drugs done for myeloma that is extramedullary?
Well, so the true evolution of these past few years has been with our T-cell redirecting therapies, of course. But if you look at T-cell engagers, or also called the bispecific antibodies, or if you look at CAR T-cell therapy, and you look at their responses, when you look at the subset of patients who receive these great therapies that truly are revolutionary in our field, the response rates are always lower for those patients who have true EMD. And so it's a need to improve on, the responses are still way better than what we had before, but they're not as good as the responses that we see in patients who do not have EMD.
So, I've rarely seen one trial get two papers in the New England Journal. And this is one trial that did that. So can you tell us, what this trial set out to do initially, and then we'll talk about the more recent update?
Sure. So we have basically two classes of T-cell engaging antibodies or bispecific antibodies. One class is a CD3 BCMA targeting class, and we now have drugs approved in that space: elranatamab, linvoseltamab, teclistamab, one right around the corner. And then we have also a GPRC5D targeting bispecific antibody called talquetamab, and these recognize different antigens on the surface of the myeloma cells. And so in the initial study here, the thought was, well, heck, myeloma cells, they're heterogeneous, and sometimes cells are GPRC5D expressing, but not BCMA expressing, or vice versa. So what if we target both of these antigens simultaneously? So a first redirect one study was done, I think, and reported at ASCO and EHA in 2024, in June 2024, I believe. And it was like incredible. The response rates were approximating responses that we see in CAR T-cell therapy. And this was like, and it appeared to be feasible from a safety perspective as well. And what was interesting in that first redirect one study that was presented by Dr. Cohen at the meetings is that there was a subset of patients in the total number of patients treated who had EMD, who appeared to have responses which were superior to what we had seen previously with the bispecific antibodies given as monotherapy.
So you guys and you and your colleagues then launched into a more concentrated effort, more focused effort. Can you tell us about that?
Sure. And so the decision was made to proceed with what was called phase 2 of the Redirect 1 study with patients with EMD only. And you can see on the slide here the entry criteria for being part of the study. So you had to have measurable EMD with central radiology confirmed. And you could have had prior CAR T cell therapy or prior T cell redirection. And most importantly, I think for those of us who see these patients, as you know, Ravi, patients who had hyposecretory or non-secretory disease could go on the study. And so the study accrued extremely quickly, 90 patients in a very short period of time. And all the investigators had these patients lined up ready to go, right? Because we didn't have other studies for them. And we treated them with talquetamab on a standard schedule of 0.8 mg per kilogram every 2 weeks. But notably, the teclistamab dosing was a little bit different than we often give it. We synced up the teclistamab with the talquetamab on an every 2 week schedule, but instead of being given at the normal weekly 1.5 milligram per kilogram dose, it was 3 milligrams per kilogram every 2 weeks. Typical step-up dosing, and then every 2 week dosing, treating until progression. And also importantly, as we know now, none of us give bispecific antibodies according to the label. We spread treatments out very quickly after we get responses, and that's what was done in this study also.
So obviously, this is a difficult group of patients to sometimes even follow. As you said, they're oligosecretory. They don't make the markers that we rely on. So how are responses assessed?
Yeah, so the critical thing here were the radiographic studies, in particular CT PET scanning. And so tumors were measured and had a certain, centimeter squared volume, and so forth. And so to judge responses, you had, as you see, a complete response here was complete disappearance of plasmacytomas, or maybe a leftover scar or fibrotic tissue. And then we had PRs and VGPRs also. And so we looked at not just for those patients who did have measurable disease, we of course measured paraproteins, but we looked at very specific radiographic criteria also.
So I have to congratulate you and your colleagues that traditionally these oligosecretory, non-secretory patients are excluded from clinical trials, and they're sometimes the most needy patients who need access to these drugs. So hopefully this will set a precedent that in the future we can enroll those patients on additional trials that we can then just use similar criteria to assess for response.
100%, Ravi. I mean, we don't need too much help treating the standard risk, early stage patients where we do so well treating them. We need help figuring out novel therapies and improved therapies in this subset of patients.
So what were the demographics of the patients that ultimately were accrued to the trial?
Yeah, you almost could predict them. They were 90 patients. Again, median age was 65, so a little bit younger than we sometimes see in myeloma trials. And patients' median of 5 years since diagnosis. Median number of therapies was 4. EMD sites were varied, including lymph node, organ, soft tissue. A few patients also had paramedullary disease in addition to extramedullary disease. Tumor volumes varied from just a few centimeters to much larger. And over a third of the patients had either non-secretory or oligosecretory disease. And also, a lot of these patients had prior BCMA therapy, either belantamab or an anti-BCMA CAR. And a few patients had cevostamab as well. And they were all really refractory patients, so challenging patients to treat.
And what were the results?
Wow. And so this is how you get 2 New England Journal papers with the same study within a year, right? And so it's overall responses 79%, and most of those responses were complete responses. They're very good complete responses. VGPRs, a few partial responders, and the median duration of the response so far has not been reached. The 12-month duration of response is 62%, which in this population of patients is really good. We'd like it to be better, of course, but that's really good for this group of patients. And so, really, I think we verified and substantiated the findings from the original Redirect 1 study in this group of patients.
Amazing. And so in terms of any specific signals as to which subgroup of these patients responded better than
I think
others?
the only thing that stood out, Ravi, was that the patients who had very large volume EMD, larger volume EMD, had lower response rates, as you can see in the very right side of this graph. They had lower response rates than those who had smaller tumor volumes. And we found that in the patients that we treated on this study as well. And that was the big thing there. And if you had organ EMD, the median duration of response was not reached. If you had non-organ EMD, it was 15 months, which is still pretty darn good. And that would example of that would be muscle disease, for example.
And how was it tolerated?
Yeah, so tolerated as you might expect. And so when we give the BCMA T cell redirecting therapies, we see some cytopenias, but mainly we're concerned about grade 3-4 infections, which we're seeing in a third of the patients here, grade 3-4 infections. And those are significant infections. And I think we've all gotten better at giving these T cell engagers in a more safe fashion, right? I mean, we now give IVIG preemptively, and here it was given reactively for levels, and not all patients got it. Only 3/4 of the patients got IVIG, and so I think that was the main thing to look out for infection here. Now there were some grade 5 events on study, and you see those at the bottom there with Klebsiella, COVID, some Pseudomonas, E. coli. And of the 6 grade 5 events, 3 of those patients had never had a dose of IVIG. I think that's really important, and we certainly have adopted here at CBCI preemptive IVIG with our CD3 BCMA T cell engagers.
So a couple of questions before we kind of wind up. First of all, you mentioned that the larger tumors maybe didn't respond as well. There's this thought that even with CAR T, maybe if you radiate these patients and then come in with some kind of immunotherapy, that they may be better tackled. What do you think about that approach?
I love that approach. And I think we discussed this last week at the conference where we were at as well. So I think it's a great idea for a couple of different reasons. One is to, if you will, to give additive or synergistic therapy to address larger plasmacytomas. But I think there might be some sort of abscopal effect, if you will, from getting T cell antigens out there circulating. And so we definitely, with T cell redirecting therapies, be it a T cell engager or a CAR T cell, like to radiate our larger plasmacytomas. And
the last one is, what else is on the anvil for these extramedullary disease? We have a lot else happening, obviously, in myeloma, trispecifics, new CAR Ts. What is your hope for those new treatments?
It would be nice if the trispecific pans out. It would be really nice, because one of the things we haven't talked about with this combination is that when you do the talquetamab in this aggressive schedule, 0.8 every 2 weeks, patients do get taste disturbance. Some of them get weight loss. Patients do have some tolerability issues. One of my patients had severe anhidrosis and had to come off talc but he couldn't golf because he just overheated on talquetamab. And so the trispecific, I'm kind of hopeful there, because it's engineered a little different than talc and tech separately, and it also has a very favorable schedule of administration for patients, as you know, with monthly dosing. And I think some of the novel CARs also here may have a role as well, Ravi.
Well, again, I want to thank you very much for this extraordinary pieces of research that your colleagues and yourself have contributed to, which has, I think, helped patients across the world, and will continue to be followed up with additional studies. And I'm sure you're going to be doing more, and hopefully I can have you back to talk to us about what more you achieve.
It was a real pleasure to be with you and to be able to share some stuff with your audience, which is pretty exciting.
Thank you very much.
Thanks, Ravi.